So I'm Dr. Susan Hickman. That is my dog moaning, by the way, if anyone heard that. I'm the director of the IU Center for Aging Research here at Regenstrief, and I'm really delighted to be here today to introduce one of our IUCAR investigators, Dr. NiCole Keith. She's a professor in the Department of Kinesiology and the Associate Dean of Faculty Affairs in the School of Health and Human Sciences. Dr. Keith is dedicated to research and programming that affects physical activity, participation, improves fitness, and positively influences health outcomes while addressing health equity issues. She has served as an IUPUI faculty member since 2002, and as I indicated, she's one of our research scientists. She also co-chairs our DEI Council for Regenstrief Institute. Additionally, she serves as the American College of Sports Medicine president this year, right? I think that's correct. You're almost at the end of that term.
My term ended Monday.
Monday, wow. So we get you fresh off your presidency. She also serves on the ACSM's Exercise and Medicine and American Fitness Index Advisory Boards, as well as multiple other ACSM national committees. She earned her BS in physical education from Howard University in 1992 and has a Master's of Science in Exercise Science from the University of Rhode Island and a PhD in Exercise Physiology from the University of Connecticut. She also has a second master's degree. I don't think you put these all in your credentials, NiCole, but you should. It's very impressive. A second master's degree in clinical research from IU in 2011. I am really delighted to introduce her for her presentation today. As I indicated, her area of expertise is in exercise and health promotion and in building sustainable community programs for adult fitness. She's worked with patient populations in Indianapolis for 2 decades, and we're really delighted to have her as one of the investigators in IUCAR. I'm going to turn the floor over to you, NiCole, to get us started.
Okay, thank you for that great introduction, Susan. I really appreciate it. I'm going to go ahead and share my screen. And Susan, I'm going to check with you to make sure that people are seeing what I want them to see.
So far, so good. And I also will just note, NiCole and I talked in advance, and if you have questions, go ahead and submit them in the chat, but we're going to hold on her answering those until the very end. So.
Thanks, Susan. And I can't actually see the questions, so it's not that I'm ignoring you. I just can't see them. So you're seeing my big slide and not my note slide, right? Okay.
Correct.
So the title of my talk is Weight Loss Disparities Among Black and White Women, 20 Years of Clinic Partnerships, Research, Recruitment, Enrollment, Randomization, and Outcomes. But before I get started, I wanted to use this platform to kind of go out on a limb and commemorate lesbian, gay, bisexual, transgender, and queer or LGBTQ plus Pride Month, which is currently celebrated each year in the month of June to honor the 1969 Stonewall Uprising in Manhattan. The Stonewall Inn was one of the most popular gay bars in New York City, and the Stonewall Uprising was a tipping point for the gay liberation movement in the United States. On that day, a series of events between police and LGBTQ plus protesters and supporters that stretched over 6 days. It was not the first time that police raided a gay bar, and it was not the first time that LGBTQ plus people fought back, but the events would unfold over the next 6 days and would fundamentally change the nature of LGBTQ plus activism in the United States. And as I continue my journey of diversity, equity, and inclusion, I've tried to use every opportunity to learn about the history of my fellow humans, and I encourage you to do the same. So thank you for giving me the opportunity to take an alternate route on the way to my presentation today. Again, the title of my presentation is Weight Loss Disparities Among Black and White Women, 20 Years of Clinic Partnerships, Research, Recruitment, Enrollment, Randomization, and Outcomes. It's a long title, but you'll see this work continues to be a long and rewarding process. So an overview of my presentation is that first I'll discuss my formal intervention training on an NIH-funded study entitled Sister Talk. I'll then discuss my first attempt at conducting an intervention on my own through another program called Soul Empowerment. I'll then describe my work with a program that's been the focus of my research for the last 18 years, first called Take Charge Lite, which is a weight management program funded by the Fairbanks Foundation, and then later taken over by Sekenazi Health because it's a really great program, and it's now named HealthyMe, with more of a focus on lifestyle management. Throughout, I'll discuss some trends that I and others have discovered over the years that has led us to my current R01 with Dan Clark, entitled Addressing People, Places, and Microenvironments for Weight Loss, or Because We Love Acronyms at Me. So first, starting in the summer of 1995, I worked with Kim Gans and Patty Rissica on a really complicated weight control intervention entitled Sister Talk. It was also a great learning experience for me. Sister Talk was designed specifically for Black women using cultural tailoring and the social action theory. The program was delivered through cable television, and the intervention content included nutrition, physical activity, stress reduction, and self-management. Throughout the intervention, there were behavioral analyses that examine how Black women view weight. The process evaluation included how to use community networking for both recruitment and enrollment. And we used both quantitative and qualitative data collection. And that was my first experience with qualitative data collection, which is now one of my major methods of data collection. We also used social marketing. And remember, this was the 1990s before social media was even a thing. But these scientists understood its usefulness, and they were really cutting edge. And we examined cultural anthropology to try to understand whether Black women in Boston, where the study occurred, engaged with one another around weight-related behaviors. As we developed the television show, we used the process evaluation to make sure it was politically practical, culturally sensitive, and appealing to the target audience. Through this process evaluation, we learned that women wanted to learn about how to employ healthful behaviors regardless of their weight. The women preferred an all-Black female cast, and this holds true today in research that shows that people are most comfortable in homogeneous groups. But today we know that diverse groups perform better, and that's a different story for another time. Anyway, the cast included a nutritionist, a personal trainer, and a social worker. And for the first 40 minutes of the program, the nutritionist and the personal trainer presented pre-recorded content of the weekly topics. Nutrition topics included reducing fat consumption, making calories count, increasing fruit and vegetable intake, healthy shopping, and eating out. The physical activity topics included increasing lifestyle and leisure time activities, moving more throughout the day, and decreasing sedentary behavior. There were also 10-minute activity breaks, and the weekly show ended with a live discussion that included a featured guest, and the women, depending on which group to which they were randomized, had the opportunity to call for positive reinforcement and problem solving. So the study design was a 2x2 factorial comparison of the interactive versus passive programming and the phone support versus no phone support. The phone support was provided by community outreach educators, or COEs, who are Black women from the community. The COEs underwent 20 hours of training and then delivered 12 weeks and 4 monthly social support calls several days after each show to discuss participants' progress and help them problem solve through their behavior change process. They also provided encouragement for the participants to continue to move through their goals. The COEs were trained to answer simple questions and were directed to us, the research staff, for more complicated ones. At the end of the 12 weekly shows, all women received booster videos at month 4. Assessments were taken at baseline as well as at months 3, 8, and 12. And the measures included demographics, psychosocial variables, food habits, and physical activity. The physical measures included height and weight, which were used to calculate BMI. We monitored television viewing by calling the women within 2 days of the shows and asking questions about the content. If they answered them correctly, they received an incentive like a t-shirt or a water bottle. And we also used the COE support logs for qualitative data collection. There were 6 waves over a 3-year period, and ANOVA was used to measure differences over time between the groups. So you'll see in a moment that I was long gone before the first paper was published. And the last paper so far was literally published in January 2021. So I can't take much credit for any of the writing, but I think you deserve to know briefly what happened. In looking at these tables, they reminded me of some important lessons learned throughout the study. When the study started, the focus was on African-American women, and that's what all of the recruitment material said. And while we were recruiting in what seemed to be appropriate places, our recruitment efforts were quite poor. We learned that many of the participants identified as being Black, but not African-American, and so they didn't think the study was for them. We changed our study materials to say Black women, and our recruitment efforts greatly improved. It was interesting to see so many women from different ethnicities who all self-identified as being Black. This group of women was also pretty educated, with the majority of them living above poverty and either living with a child, spouse, or both. And unsurprisingly, because this was a weight loss study, the majority of women were overweight or obese. There's more about their level of obesity on this slide, and along with their self-reported comorbid conditions, food habits, self-reported physical activity, BMI, and weight, which were measured. And this table shows the difference in the major outcome variables at baseline and across time within and between groups. There were improvements in self-reported food habits at months 3 and 8, but those differences faded over time. Throughout the study, some groups showed differences in BMI and weight, but in the end, it appears that the behavior change did not hold. This table demonstrates the number of shows watched and the amount of written materials that were read. During the study, women assigned to the television groups would miss shows for a variety of reasons that mostly had to do with competing priorities. What carries forward today is that asking people to commit to a certain day and time to participate in behavior change interventions seems to be problematic. So as I reflect on what else I learned in my first exposure to behavior change interventions, this is what comes to mind. First, formative evaluation is important. The PIs could have just developed content that they thought would resonate with the target audience, but they didn't. From the title to the logo to the content, we went through the difficult and very time-consuming process of cultural tailoring, community-based participatory research, user-centered design, and implementation science. Back then, these efforts were extremely innovative. I also learned that the importance of appropriate communication and social interactions, not just with the research team, but also with the participants and the COEs. There were problems with the COEs that we didn't understand until the research was well underway. They were invaluable in the formative evaluation and recruitment, and they enjoyed it. However, when it was time for them to deliver the intervention, we found that the COEs far more enjoyed interacting with the research team than the research participants. As a result, their work quality suffered, and so did the study outcomes. Still, a lot of data were collected for this research, and while it did literally take 10 years from the initial funding period to the first publication, a lot of pubs came from the study. As I mentioned when I started describing Sister Talk, I was long gone when the first pub happened. In fact, I was already an assistant professor at IUPUI. However, if you're interested in learning more about Sister Talk, there's a development paper and an assessment paper and 2 descriptive papers and a paper with the final outcomes, but that's not the final paper because, as I said before, the final paper was published last month. And while I was not offered an opportunity to help with the writing, I am in the acknowledgements of every paper, and I learned other skills that I carried forward to my first faculty position. So I accepted a tenure track faculty position at the University of Southern Indiana in Evansville. And once in Evansville, I started looking for a neighborhood organization where I could conduct my own community-based participatory research studies. I met a nun, Sister Jane, who was assigned to a Catholic church, a small Black Catholic church in the middle of inner city Evansville. It was attached to an old elementary school that was essentially empty except for CCD classes, which is the Catholic equivalent of Sunday school, and a weekly food pantry. Sister Jane wanted to keep the building open and occupied. She was also concerned about the health of her parishioners. It was a perfect setting to start a research study, and Sister Jane named the program Soul Empowerment. She and I wrote 2 separate grants to the Wellborn Baptist Foundation, and both were funded to hire a community outreach organizer, a health fitness instructor who could supervise undergraduate students, buy exercise equipment, and to pay rent to the church. While we were working on that, I began the process of holding focus groups in the school and learning what would attract or deter participants. I repeatedly heard not to focus on weight, but instead on health. So that's what we did. The comorbidities we measured included hypertension, cigarette smoking, high cholesterol, and diabetes. And over a 1-year period, we recruited 351 participants, most of whom were younger to middle-aged women and obese. The undergraduate students led personalized exercise programs that were culturally tailored to the Soul Empowerment members. And then we measured the heck out of them. We considered their attendance, their BMI, their body fat through bioelectrical impedance analysis, heart rate, blood pressure, total cholesterol, fasting glucose, and took several circumference measures. Here I present the baseline and 6-month follow-up data. There were no improvements in BMI or body fat, but that wasn't the focus, so that was okay. Both the diastolic, resting, and recovery blood pressures improved, and while there wasn't weight loss, there were improvements in bicep, waist, and thigh circumferences. We were able to draw some valuable conclusions that the exercise program could improve some fitness outcomes. Maybe bioelectrical impedance analysis isn't the best measure of body fat, and that dietary changes were likely necessary to show conclusive changes in overall body composition, cholesterol, and blood glucose. I also learned firsthand how to establish community partners and how to really perform community-based participatory research by asking the community members what they wanted and how their problems might be consistent with my research goals. It was also the first time I engaged undergraduate students in research. They were great, as was Sister Jane, but I had no academic colleagues helping me with the research. USI was and is a teaching institution, so I was still required to teach 8 classes a year. Yes, 8 classes a year. It was impossible to conduct research and teach such a heavy load. I really didn't understand that when I took the job, and we still had 3 daughters at home, and my husband couldn't find a job in Evansville, so he ended up taking a job in Indianapolis, almost 4 hours north. This wasn't ideal, and my department chair at the time was a wonderful person who helped me start looking for positions closer to Indy. I ended up with job offers at Indiana State and at IUPUI. Obviously, IUPUI was a better situation for several reasons. First, it was in Indianapolis where my husband lives. And second, it had a medical school on campus. Third, it was a Research 1 institution. And fourth, my teaching load was lighter. This time only 5 classes a year. Yes, 5. When I arrived on campus, a senior colleague walked me over to the IU Center for Aging Research, and there were 2 faculty members who were looking for a physical activity researcher who could do some community-based physical activity interventions. So I met Chris Callahan and Dan Clark, and they almost immediately said I was teaching too many classes and negotiated with my dean to buy me out of 2. I started shadowing physicians as they saw patients during clinic visits so that I could better understand both the health system and the patient population within Indianapolis. And as Susan mentioned in my introduction, I did earn a K award and was able to get another degree in clinical research, so I better understood the health system. Dan and Chris served as my primary mentors for the K award until I was awarded tenure, and we're still close collaborators. But in 2003, Dan and I created Take Charge Lite, a clinic-based weight loss program. So Take Charge Lite was delivered at the Wishart Health System. And for those of you who are newer, this was the public and safety net hospital for the uninsured and underinsured. And the main hospital was located just across the street from IUPUI's campus. Wishart also had 12 at the time federally qualified health centers located in low-income neighborhoods around Indianapolis. The health system served over 1 million patients annually, and it was a great resource to develop a program and then conduct some research. So we got started. We developed what the patients, providers, staff, and administrators told us that they wanted: an adult weight management program that removed common barriers such as access, because it was located in the clinics where all the other care was provided. It was offered in English and Spanish. It was free of charge to patients. We even had clinic computers programmed so that the providers wouldn't have to remember to refer overweight and obese patients to Take Charge Lite. And here's how it worked. Patients would have a FQHC visit, and when the visit was complete, if the patient was 18 years of age or older with a BMI of 25 or higher, the provider would be reminded that the patient was eligible for Take Charge Lite at the time that all of the other orders were written. And then with a single keystroke of the computer, the Take Charge Lite prescription was written. The patient received information about Take Charge Lite at the checkout. And within a day or two, the Take Charge Lite coach would schedule a visit with the patient. The visit involved a weigh-in and other assessments. And then the patient would work with the coach to set goals, and depending on what the goals were, the coach would refer. This involved going to a dietitian within the FQHC, attending a group support class that was hosted by the coach and included diet and exercise sessions, or seeking behavior change activities away from the FQHC. Our strategy was grounded in the 5 A's of behavior change theory, which includes advise, assess, assist, arrange, and agree. The initial assessment included weight history, lifestyle behaviors that were related to weight, knowledge of obesogenic behaviors, self-monitoring habits, motivation to lose weight, and confidence that the weight loss was possible for them. And then, as I mentioned on the previous slide, Take Charge Lite participants would work on goal setting, a behavioral plan, and referral with the coach. Initially, this was a quality improvement program that was funded by the Fairbanks Foundation to evaluate patient enjoyment and other health outcomes that targeted weight loss and improve health behaviors. As I mentioned earlier, we used community-based participatory research to develop an inclusive design. Our funding was very adequate for both staff support and patient incentives. We thought we eliminated every possible barrier, but noticed a concerning trend that I'll share with you shortly. In our first Take Charge Lite publication, we reported providers' attitudes towards obesity in general and their obese patients in particular. We learned that providers felt many of their patients had too many problems to manage obesity alone, but had confidence in Take Charge Lite as a program. The patient measures included BMI, sociodemographics, and from the electronic medical record, we pulled their chronic illnesses, substance abuse history, and history of pregnancies. We learned that the average age was 50. Most of the participants were women. 28% self-reported being African-American or Black, 21% reported being Hispanic, and the remaining participants were white. Below BMI, you can see the percent from each BMI category that received a referral. Interesting, the largest percentage of referrals came from Class 1 and Class 2 obese categories, and 34% of the referrals were people who were living with diabetes. Information from the previous slide and more can be found in our first publication. In our second publication, we reported more long-term outcomes, but what we were finding is that a very small percentage of the participants who were referred were actually attending regularly, despite our removal of barriers in our inclusive design. Of even more concern is that even though these people largely lived in the same kinds of communities, had the same level of education and the same level of income, Black women in Take Charge Lite were losing 50% less weight than white women when all other variables were the same. We started reviewing the literature, and this was true in other weight loss interventions as well, but we weren't sure why. Meanwhile, 3 years had passed. I needed to get promoted. So we decided to pause my involvement in this research related to Take Charge Lite and work on data collection that had a faster return. There was nothing related to weight loss for me for 4 years, but the world around us was changing. So Take Charge Lite was this nice little program that everybody liked, and it continued. But then Sydney and Lois Eskenazi donated $100 million to Wishard at the Indiana Health and Hospital Corporation to build this big, beautiful hospital and call it Sekenazi Health, which is familiar to most of you today. We moved our offices out of the old Wishard offices and into the HITS building, and then later on to our new Regenstrief Institute building. Another big, beautiful building that mostly sits empty right now due to the pandemic, but we'll get back there sometime soon. I actually saw the email from Peter yesterday, so very soon, which is great. And most of you know, the whole building was designed around facilitating research collaborations, which is also great. Well, I finished my other projects and earned promotion in tenure. Sekenazi began including Take Charge Lite in its annual budget and renamed it HealthyMe. There was so much great publicity around the program, and patients, providers, staff, and administrators were all using it. They still continue to do so. And here's a testimonial from one patient. It says, "I was overweight and having pain, including back pain. My doctor referred me to the HealthyMe program to lose weight. It's convenient, right in my neighborhood, and doesn't cost me anything. They give me the proper way to exercise, and they've been very helpful." I completed my other projects, and now post-tenure me was able to go back and work with Dan on these weight loss questions to explore why Black women lost less weight than everyone else. We performed a series of in-home interviews with both Black and white women and published a paper called Weight Loss Attitudes in Social Forces in Urban Poor Black and White Women. The purpose of the study was to explore differences between Black and white women in perceived influences on weight-related behaviors. We interviewed 27 HealthyMe participants who were referred and never attended or stopped attending HealthyMe. The in-home semi-structured interviews included the use of a script informed by a focus group that I developed prior to the start of the study. We then employed the theory of planned behavior to learn about participants' weight loss attitudes, social forces, and perceived behavioral control. Our findings indicated that Black women in the study reported eating for positive reasons, while white women reported having more social support and social pressure for weight management activities. White women also associated eating with negative emotions such as depression, anxiety, loneliness, and boredom. And I pulled a couple of quotes. The first one is from a white woman, and it says, "Thursday is the meeting, and then after the meeting and all, they're going up to the country buffet and have their lunch, going to get their money's worth." The second quote is from a white woman, and it says, "I mean, it's just like, as far as losing weight, it's kind of like a cold. You kind of know, or sorry, you know, you'd like to get a shot and not have a cold the rest of your life. Get a shot and not be fat for the rest of your life." This table presents some of the categories that we revealed from Black and white women, from Black women only, from white women only, and from both groups regarding weight loss attitudes, social forces, perceived behavioral control, and the environment, and reported behavioral intentions. We concluded that social relationships and emotion may be critical factors in weight management and lifestyle program participation. The next paper we wrote was entitled "Identifying Contextual and Emotional Factors to Explore Weight Disparities Between Obese Black and White Women." This study evaluated the feasibility of identifying daily contextual features in the lives of obese Black and white women that may influence weight. Our participants included 16 obese urban poor women. The RAs and the study participants were race and gender matched. The RAs performed in-home measures without telling the participants. We gave RAs a checklist of in-home observations that we identified as being associated with obesogenic cues. For example, was a TV on? Was there food visible? Or was there exercise equipment visible? RAs delivered in-home surveys. We also used ecological momentary assessment, or EMA surveys, to capture emotion every other day. Then the RAs delivered a day reconstruction survey over the phone the next day to reconstruct the context of the prior day's EMA. From the EMA and the day reconstruction, we created variables representing context, activity, and emotion, and categorized them as fixed and time varying. This, again, was a very busy study that once again generated a ton of data. The groups were too small to perform statistical analyses, but demographically, these women were very similar, if not exactly the same. This was consistent with what we'd experienced with the patient population over the years. And I'll give you a second to just look at the table. When we looked at the fixed and contextual factors, we did notice some potential differences that deserved further explanation and exploring. For example, the number of TVs in the kitchen and having a weight scale in the home differed between the Black and white women. I couldn't present the third table in the picture because it's 2 pages long. However, I wanted to point out some interesting findings. We sent 40 EMA text messages on 6 days over a 14-day study period. The participant response rate was 74%. Over that same 2-week period, there were 6 attempts to complete day reconstructive method surveys, and 90% were completed. The most frequent locations were in their own homes, at work, or at the home of a social contact. The most frequent activities were working, watching TV, napping, eating, and relaxing. And I've listed the other activity options here. The most frequent emotions reported were happy, tired, and warm and friendly. And I've listed the other emotion options here. Each time an EMA was sent, we asked the participant if they could see or smell food. Black women reported food exposure around 16 times and white women around 14 times, but there was high variability. Lastly, we asked if they were with anyone, and if they were, they got a follow-up text asking whether food was discussed. And regardless of the answer, we asked if they felt supported in the conversation. From this study, we concluded that identifying individual contexts may lead to valuable insight about obesogenic behaviors and new interventions to improve weight management. From my experience with Take Charge Lite and then HealthyMe, the focus group interviews, the in-home interviews that we conducted, and the in-home assessments done by the RAs, we learned a lot more lessons. First, human behavior is automatic and likely humans respond to cues. There were a lot of obesogenic cues in the homes and lives of these women. Weight loss interventions provide information about managing cues, but they may not be as useful in the moment. Dan Clark started investigating the field of automaticity and could demonstrate that humans primarily manage behaviors through habit. The good news is HealthyMe has been around now for 18 years, the same age as my son, who graduated from high school on Monday. The bad news is that patients who go have modest weight loss success, and Black women are still losing 50% less weight. We also were at the point where we knew that 2 pounds of weight loss is associated with a 10% reduction in the 3-year risk of hypertension and a 16% reduction in the 3-year risk of type 2 diabetes. We were fully aware that 50% less weight loss meant a substantial lost opportunity of obesity-related mortality. Finally, we know that the Healthy People 2010 final review reported no progress on racial disparities in obesity and called for new and innovative research efforts. Dan and I got to work as co-PIs on an R01 entitled Addressing Place and People Microenvironments and Weight Loss Disparities. It was funded by NHLBI on the second try in 2016. Specific aim 1 is to capture obesogenic cues as they occur in the daily life of among 100 obese Black and 100 obese white women ages 35 to 64 years who have received an FQHC provider referral to HealthyMe weight management program. We hypothesized that Black women would experience more Q exposure, and racial disparities in obesity are statistically reduced in models that adjust for Q exposure. The specific aim 2 is to randomize 240 adherent aim 1 participants, 120 Black and 120 white women, to HealthyMe usual care or to HealthyMe plus 6 months of mHealth delivered Q alerts, which we call priming. We hypothesize that more participants in the priming aim will lose 2 kilograms or more of weight, and that racial disparities in 6-month weight change will be less in the priming arm. First, we had to develop an app, so we hired 2 UX designers and a graduate of the Heron School of Art and Design on our campus to design an app at the front end. We bought a FTE of 2 programmers from CBMI to work on the back end of the app. And then I used my qualitative data collection skills to learn about what women would want in an app. They said they wanted messages from pictures of people they knew. The messages on the top right, or the message on the top right, is from Shamika, who's one of the HealthyMe coaches. All the coaches were willing to pose for us, and so they're all included in the app. And Jennifer Carnahan, who we all know from the IU Center for Aging Research, and who is also my parents' primary care provider, also agreed to modeling for us. I had to talk her into it a little bit, but she did it. We also have images and quotes from famous people like Alice Walker, Joel Osteen, and the Obamas. Lastly, we have colorful pictures of healthy food and exercise reminders. In total, we have approximately 600 messages and images. During onboarding, the RAs also showed participants how to create their own messages within the app using their own photos, just in case a sister or a spouse was inspiring to them. And remember the text messages from our pilot? Well, we had that built into the app as well, except for now it was much more user-friendly. It can be used on an Android smartphone, and if the participant doesn't have one, we loan them one and pay for the plan. And for 30 days, we learn about their behavior patterns by sending them 8 to 12 EMA surveys at times that they tell us they're awake. Then women who answer at least 50% of the surveys are randomized to usual care, which is again HealthyMe, or HealthyMe plus the app. And here's a little more overview of our methods. So our RAs receive a list of women who are eligible for or referred to HealthyMe and who meet the study criteria. The RA sends the list generated by Evgenia in Data Core to the HealthyMe coaches to make sure there are no concerns about anyone on the list. Our RAs are then deputized by ResNet to contact patients and administer a screener to confirm eligibility. The study RAs then schedule and administer informed consent and in-home baseline assessment and provide data collection tools. We collect 4 weeks of data to satisfy aim 1. And for those randomized to usual care and have a phone, we get the phone back. Participants are weighed again and are randomized. One of the RAs remains blinded and completes the 6-month follow-up. Again, we're taking several measures to learn more about these participants. Most we get during the in-home assessment, but some we pull from the electronic medical records. And you can take time to take a look at that. As I mentioned, we're 6 months into year 5. We have finished enrollment and will complete the last follow-up in October. We have 1 paper published. I have 1 under review using the EMA data from about the first 200 women, and Dan has 1 under review regarding the study process. So each of the previous lessons learned were carried forward. Each success and failure was a learning experience. Several weeks ago, Dan and I told our research team that we've been at this for 20 years, and he's actually been at it for 30. And sometimes it feels like we've made no progress, but we have, and we'll keep trying. We understand that weight loss is complicated, and intervening on behaviors that are steeped in a generation of obesity is even more difficult. Over the years, I've also learned that weight maintenance is important, and if a participant doesn't gain weight, for me, it's a win. It seems fairly unreasonable to ask adults who have been obese their entire lives to change their eating and sedentary behavioral habits. Changing the environment and opportunities to be active may result in more success. I'm also hopeful that new technology may provide additional opportunities for supporting healthy behaviors to both understand obesogenic behavior and intervene outside of a clinic visit with social support, education, and motivation. Lastly, I love this population. They're amazing and have taught me so much over the years. However, working with humans in general and those who are trying to lose weight is complicated, and it's sometimes difficult. I learned early to pick up a parallel line of research so I could take appropriate steps to do community-based participatory research the right way. I'm grateful for my experiences. I'd like to thank, I obviously can't thank everybody who was engaged in my last 20 years of obesity research, but I did want to point out members of IUPUI who participated in the research study I listed, and I want to thank you for listening.
Thank you so much, NiCole. I'm going to now open the floor up for comments. People are welcome to post them in the chat. Comments and questions, post them in the chat or unmute themselves and ask them. I think we could pull that off. And I'm going to actually kick us off. I'm curious about what comes next. So that was a great overview of where you've been and the journey you've been on. I'm curious sort of what your next direction and goal is.
So we tried a couple of years ago to try and do next steps for HealthyMe, and the reviewers were unimpressed that we were trying to do next steps for a randomized control trial and we didn't know what the outcomes were. So we have to learn about whether or not this worked first, and then understand how we're going to use it next. But I really believe that we have to come out of the clinics where it can start in the clinic. We have to come out of the clinics into the community and meet people where they are. I like to say, meet people where they live, work, play, and pray in order to help them have healthy behaviors.
Great, so that sounds like a message to stay tuned.
Yes, yes.
Hey, this is Dan. NiCole, that was a fantastic review. I really enjoyed it. I had forgotten how much you have done over all these years in this area. And just wanted to thank you for doing that. Made me feel a little bit more optimistic about our efforts here. One thing you reminded me though is potentially the really critical role of social and emotional factors, but how they might differ for Black and white women. And you know, we have this one in HealthyMe right now. We haven't finished the final results, as you said, but we do know, just looking at the change over time in the whole sample, that Black women with anxiety actually lost a bit of weight, and white women with anxiety gained quite a bit of weight. And I've been struggling to figure that out, but your review today made me remember that work on your paper a few years ago, talking about the social and emotional differences for Black and white women. And I think that could be what underlies that rather remarkable difference.
So first I want to say that Dan Clark saying that he feels optimistic is a miracle for those of you who know him. And I also want to thank Dan because, as you can tell, he's been instrumental in my career development since I got here. So really for 18 years. So thank you for that. It is really stunning. And even when I published the paper, the reviewer said, I hope this isn't correct, because it is really stunning the different way that Black and white women view weight, and where white women who are obese feel hopeful that weight loss can happen. Not only do Black women not feel hopeful that weight loss can happen, but really don't see the need for weight loss to happen because it's socially and culturally acceptable for them to be overweight and obese within their networks. Having said that, we have had some success. And I did learn this when I was in Evansville, but again, I've forgotten, and that's why I wanted to go through this exercise, that while Black women don't really get excited about talking about weight loss, they do get excited. We do get excited about talking about health and longevity and being good caregivers for our children or other family members. And so that may need to be a different focus. And Dan, as you comment, that maybe these social forces among Black women are very different and that we can't create interventions in the same way for everyone. They have to be more culturally tailored to what resonates with a particular individual or group of people.
Great, thanks, NiCole. There are a couple of questions in the chat. And a few enthusiastic comments as well.
So I'm going to do this question. Can you say a little bit about the role of social networks and cultural beliefs associated with weight loss and how this new R01 is addressing them? And so I can say a little bit about this. I don't know how the new R01 is really addressing the social network piece. We've had a lot of conversations about how we could create apps around social relationships and having groups like a friends group. But we get a little bit concerned about whether that might be positive or negative. And if we're having people who have supported each other in weight-related behaviors but have not been successful in weight loss, whether that might be detrimental to a weight loss intervention, but maybe not detrimental to a healthy lifestyle intervention. But right now, there's really no interaction. So in the pilot, we actually had our RAs texting the participants and then calling them every other day. So there was some social support, but that's not really sustainable with 240 people. So there's no social interaction right now. But in terms of cultural tailoring, before the app was created, we did do focus groups and ask the women what they wanted in an app and how that would look and what they would tolerate in terms of us sending. We're not sending the messages are coming from a server. So there's no human behind the messages. But it seemed to us as well in the focus groups that women were really excited about potentially having a human behind the app. And so it could be, if this app works, that maybe we arm the HealthyMe coaches with the app so that they can have both the app and social support.
Great, thanks, NiCole. I see there's also a question about asking you to comment on the neighborhood level variables and how those could impact weight loss.
So absolutely, the neighborhood level variables, including the built environment variables, as well as food resources, including fast food and grocery stores and convenience stores, could all influence weight-related behaviors. But we decided not to evaluate them because, as I mentioned earlier, the women all lived in the same communities. So it wasn't like they were in different zip codes, and everybody was in Marion County and Indianapolis. And we've even tried to look at these by county, by township, to see if, it's a township issue, is it a zip code issue? And I will say that Jason Hackett spent a considerable amount of time trying to break these up to see if it has something to do with where they're living and if they're living in different places, but it doesn't. There's just no community difference. And fortunately, you can get on the Marion County Department of Public Health website, and it will give you by township level what the resources are, what the challenges are for each township, and they're not different. And so while I agree that the built environment and community level variables certainly influence weight-related behaviors, that does not explain the 50% less weight reduction in Black women because they're living in the same communities. But really great point.
Thanks, NiCole. Are there other questions or comments? Again, some
Hi,
nice.
this is Lexi.
Oh, great.
I have a question for NiCole. Given that there are both positive attitudes about eating and about among Black women, where it's sort of, it seems to be something that's associated with being social and also positive attitudes towards body image, which, although I realize that obesity has negative health effects, I think that there's something, that's of course positive about, acceptance of one's body. So what are your thoughts about how to craft messages that both promote weight loss, but don't seem to be sort of undoing some of those positive aspects around and positive views around food and eating?
Yeah, so I am really careful about body image, and they are not presented in this presentation, but I have done physical activity interventions where I don't talk about weight at all, because there are benefits to physical activity participation. It doesn't matter if you lose weight, you'll still have physical benefits to physical activity. And I agree, and I did get to the point, and I mentioned it in my presentation, where I felt like if you don't gain weight, it's a win. And so if we can create this energy balance where you can continue to eat, you can continue to eat the foods that you enjoy, you add some other foods that maybe weren't part of your diet, but that are palatable to you or even enjoyable to you. And I know that Sekenazi does a really good job of having, in the HealthyMe program, having people sample foods that they hadn't tried before. But to really, I agree with you, Lexi, continue the enjoyment of eating, because it's not just an activity of mechanical necessity. It's also, there's also a social component around it. So I do think that creating interventions where we're not taking your food away, but we're just asking you to view it differently, and to increase your activity and decrease your sedentary behavior is really the way to go. And I liked when Dan started talking and teaching me about the theory of automaticity and understanding, is it a kitchen cabinet clean out? Is it making sure that you put your food away? Is it having cues that remind you, or keeping a pair of shoes that are comfortable walking shoes in your car, so that if you have an opportunity to walk, you can, or to put fruits on the counter so that your first go-to is not a bag of chips, but instead it's a banana or an apple. And really not being hungry. And it's really important also, because that's when you start making poor decisions around food, is when you're hungry and you're just gonna grab the quickest, closest, easiest food item that might not be the healthiest.
Thank you. I see another question in the chat from Bronson Tucker Edmonds. She writes, there's a lot of attention lately on the impact of structural racism on racial disparities. Has any of your work found relationships between perceived discrimination or even qualitative data suggesting whether racial inequality or inequity contributes to the emotional and social differences in these spaces?
That's a great question, Bronson. And yes, actually, I'm working with a colleague from the University of Michigan and another colleague who's at University of Illinois, Chicago, around running while Black. And that as especially physical activity researchers, that we really have to be careful about telling people to go outside and exercise in communities where others might not understand what it is that they're doing. And so it is, in terms of racial disparities, something that we've been paying attention to, like with the recent police shootings and the police violence, and people of color not feeling safe being outside in general, but in particular when they're exercising, because it's not as typical, and especially in Indianapolis community where the racial ethnic diversity is not great, to see people in certain communities outside exercising and feeling safe, not because of crime or not because of dogs, but because of police brutality. So it is absolutely something that we're looking at in terms of physical activity. In terms of other behavior change, including nutrition, it's not something that I looked at, but I smiled when you asked the question, because part of what's required of HealthyMe in order to get to the program is that you have to have a physician referral. And while early on, one of my first studies when I was doing my K, I was talking to physicians as I was doing the clinic shadowing about why they would or wouldn't refer a patient to HealthyMe. there wasn't this culture or education around how people of color and people who are from low income households don't get the same level of care as people who are not underrepresented minorities or people who might have higher education or meet more resources. So I do think that that could be a really interesting investigation to see if intentionally or unintentionally different races are getting referred at different rates, especially since there's this new larger Latino population or Latinx population, and HealthyMe is offered in Spanish. Are these individuals getting referred to Spanish-speaking coaches? Are they getting referred at all? I think it's a great question and not something that we've really investigated.
We have probably time for one more question. I actually have one. I'm curious, since I'm not seeing anyone jump on. I'm really curious about conducting research in the context of your intervention sort of already being adapted within the and used within the setting. Has that been a benefit, or does that complicate your efforts to study the program?
I don't think it's more complicated. I actually think it's a benefit because HealthyMe and the HealthyMe coaches see us as partners, and we're working on trying to make the program more successful. And those coaches are really committed to helping the participants become healthier. And so they see us as allies. We don't ever, I'm just checking myself to make sure that's true. And the RAs who are here can kind of chime in if I'm incorrect, but I don't think we ever ask them to do anything but review the lists. And what helps them with reviewing the lists is that they can see, because now we're not just getting people who are referred to HealthyMe, we're getting people who are eligible for HealthyMe. So they can see people who are on the lists, who are eligible, who they have not yet engaged, and they can contact them. So we're actually helping them with recruitment through the studies. So they like us. It hasn't been a problem. But I do know that we haven't engaged, or I haven't engaged with providers the way I did in the beginning. And it might be, especially based on Brownson's comment, worth revisiting because the providers are new. Probably most of the providers I started working with 18 years ago are no longer around.
Yeah, that makes sense. Well, I'll just also make sure you take a peek at all the compliments and shout outs and praise coming your direction. Greatly enjoyed your presentation. It was really wonderful to have an overview of your body of work, and I really look forward to seeing where you go next with it. Thank you so much, NiCole, for sharing this with us today, and we wish the rest of you a great rest of the week.
Thanks, and thanks to Regenstrief for inviting me. This was fun.